Well, welcome everyone. Thank you so much for taking the time to join us this afternoon, or early afternoon, or depending on where you are. My name is Jillian McConnell. I am a knowledge broker with Brain Exchange, and on behalf of my colleagues from the MS Society of Canada, particularly the Alberta and Northwest Territories Division, we welcome you and are so pleased that you're able to join us. Today's webinar is the fourth of an 8-part learning series brought to you by MS Canada. And I will post a link in the chat pod very shortly if you're interested in finding out more about our past and our upcoming future events. Before we begin, I want to take a few moments to review some of the technology we will be using this afternoon. The audio is provided over the phone, which means if you're hearing my voice, then you're all set, and the visuals or the slides are provided by an online link that you should have received in your connection details, and that's the way you can watch the slides as our presenter speaks. On the bottom left of your screen, you'll see a little blue bubble, and if you move your cursor or your mouse over that, you will see Chat with the Presenter pop up. And if you click on that, that's the chat pod. And that is how you can communicate with me during the event as well as with the presenter. I see some of you have already started accessing the chat pod just to ask a few initial questions, so that's great. I do want to let you know that only the presenter and I can see your notes in the chat pod, not the fellow participants. And that is also where you're going to be able to send your questions during the Q&A portion. I also want to make you aware that all of the participants' lines are muted for this call, and that just helps us minimize any background noise or private conversations you might be having. If you need to ask a question or have a concern during the actual presentation or webinar, then please use the chat pod, since of course I won't be able to hear you. And as I said, the presentation itself is also being recorded, and so within a week or so it will be available on the MS Canada's website as well as the Brain Exchange website. So for the purpose of today, those are the only features you really need to be familiar with. The webinar is scheduled to be 90 minutes in length, and our presenter will speak for about 60 minutes or so total, and then we'll have the remaining time at the end for any Q&A, question and answer, or a discussion. I do ask that people refrain from asking questions in the chat pod until the end of our webinar portion or the presenter portion, unless of course it's technology related, and then I'll certainly do my best to help you out, or also if it has something to do with an acronym or a definition, and we'll do our best to address that as well. Okay, so now that the technical aspects have been taken care of, I do want to take an opportunity to review a few bits of information that the MS Society of Canada has asked I share with you on their behalf. First of all, the MS Society of Canada wishes to gratefully acknowledge the educational grant received from Biogen, which makes possible this session today and the others before it and after. The MS Society does not approve, endorse, or recommend any specific product or therapy, but provides information to assist individuals in making their own decisions. And identification of needs, determination of objectives, selection of content and speakers, educational methods, and materials are the sole responsibility of MS Society staff and advisors. And we also just wanted to review the MS Society of Canada's mission statement, and that is to be a leader in finding a cure for multiple sclerosis and enabling people affected by MS to enhance their quality of life. So now, excuse me, that's taken care of, it's my pleasure to introduce our webinar topic and our presenter for this afternoon's event. This afternoon we'll be talking about cognitive and brain changes in multiple sclerosis, and we're so very pleased to have Dr. Esther Fujiwara with us today to present. Dr. Fujiwara is an associate professor in the Department of Psychiatry at the University of Alberta. She is a member of the Neuroscience and Mental Health Institute and the MS Center, Faculty of Medicine, University of Alberta. Her research interest is the intersection between cognition and emotion, and her work includes behavioral and neuroimaging studies in health and disease. She worked in different academic and research locations in Germany at the University of Bielefeld and the University Medical Center in Hamburg and Eppendorf, and Canada at the Rotman Research Institute at Baycrest in Toronto. So Dr. Fujiwara, the floor is yours.
Okay, thank you very much, Jillian, for the kind introduction. Thank you for your invitation to present here today. So as you said, my topic is cognitive and brain changes in MS and what we can do. I'm a researcher and university professor, so I'm not directly involved in treatment in MS. However, these topics are very close to my heart and currently under very intense discussion in the research community. So I'm very excited to give you sort of an overview today on the current state of knowledge in these areas. So the objectives for today, I summarize here. So first, I would like to give an overview on the cognitive challenges we do see in multiple sclerosis and how we measure them, and that's a very important point. The second objective is I want to give an overview on what we mean by brain and cognitive reserves, and the third part, or the third objective, is to learn about how to keep and build reserves, so active minds and healthy brains in the context of MS. So with regard to my sections in the webinar here, I'm going to first talk a little bit about brain and cognition in MS, and then how we measure cognitive challenges, what we actually mean when we talk about cognition in MS. Then I'll turn to the reserve concept, and the last part is what I think we can do. So as we all know, brain changes in MS refer to the immune system and how the immune system mistakenly attacks and damages the central nervous system. So what that means is we're looking at brain and spinal cord and the optic nerve and lesions. So what that means here is that we have damage to the brain's white matter. So that is fatty tissue surrounding the nerve endings. So when that happens, information throughput slows down. So if you see here on this figure, this is the myelin, and MS can affect myelin. So in addition to these lesions, there's tissue loss or actual atrophy. Mind you, the picture on the right is by no means representative of the extent of tissue loss, but I picked an extreme example here from one of our study participants to illustrate the potential for tissue loss in the context of MS. And here I think this is easily appreciable without any special knowledge in neurology or radiology that there is tissue loss going on. So if MS is left untreated, the idea is that tissue loss is faster and more pronounced in people with MS, and there's a hypothesis on premature brain aging, so-called. Again, this is not a typical finding here on the right-hand side. It's just an extreme example that I picked to illustrate this point. Now, most of these types of brain changes in MS are related to cognitive functions. Now, that said, this relationship is not a perfect one. So it's not possible to look at someone's brain scan to know definitively how cognition is affected in that person. So part of the reason for such an imperfect relationship between brain change and cognition is due to something we call cognitive reserve, and I will get back to that a little later. Now, when we do look at brain changes, there are specific regions that are more affected or more likely to be affected than others. So the thalamus is here in the center of the brain. The hippocampus, that's an important area for memory functions, as well as the prefrontal and frontal lobes. They govern things we call executive functions. Again, we'll explain that a little later. And, of course, the connection between these regions. Now, I wanted to take a few words on the thalamus changes, since these are the single most robust finding we see when we look for brain changes that are actually related to cognition. So this is just an outline I drew on the PowerPoint here. This is not precise, but it's fairly easy to appreciate that there is atrophy going on in this area on the right-hand slide. And the important factor here is that the thalamus is really a critical hub region for almost all sensory information that we process. So what we see, what we hear or feel, so in terms of touch, has to go through the thalamus. So one can then easily imagine that if such an important area gets compromised, the information that gets passed along to other brain regions gets degraded and more difficult to process further on. Now, this is a recent study we've done here in Edmonton where we measured the volume of several different brain regions in the center of the brain, so-called deep gray matter structures, including the thalamus here in red again. And we replicated a well-known finding of relationship between cognitive functions and the size of the thalamus in a group of about 40 people with MS as well. Now, just to mention, there are other brain changes that we can observe in MS. For example, accumulation of iron in the deep gray matter, which was actually the reason for this study. And we also did see relationships to cognitive functions there, but generally speaking, the white matter lesions and gray matter tissue loss are the best studied and known, especially in relation to cognition. So when we talk about cognition, what do we actually mean? And I think it's important to recognize that in order to appreciate cognitive challenges, we actually need to measure them. So in summary, the domains of cognition that are most affected are information processing speed, as well as learning and memory. We do know that attention and executive functions are also involved, and there's less evidence for effects in language or spatial cognition. Now, depending on the study, it's about an estimated 40 to 70% of people with MS who have some sort of cognitive challenge. So it's sort of an elephant in the room here. Now, when we talk about these terms, what do we mean? Information processing speed is how fast sensory information is passed on and further processed. Learning and memories is two different stages. So basically, learning is how we acquire and store new information. And then memory is how we retrieve that stored information later on. Attention functions are things like concentrating on one or more things at once. Selective attention would be concentrating on one thing and ignoring other things, so ignoring distracting information. Executive functions is an umbrella term, so this is really higher order sort of planning function, prioritization, cognitive flexibility, so essentially orchestrating everything else. Now, as I said, the language, visual, spatial functions are usually less affected, and we also don't see general decline in sort of intellectual functions. So important to note sort of the general facts about cognitive challenges in MS. They can go unnoticed or are falsely attributed sometimes to depression, fatigue, or stress. They're only very weakly related to other disease characteristics and also to disability. So motor symptoms are not behaving the same way as cognitive symptoms. And especially in higher ranges of the EDSS, the disability scale, there's very little sensitivity to pick out cognitive symptoms. They can occur at any time, but are more common later on, and they're also possible in any disease course, although they are more likely in progressive MS. very important to note, MS is not dementia. The cognitive challenges in MS are usually much milder than in dementia, like in Alzheimer's disease. The progression of cognitive deficits is also less aggressive, usually in MS than in Alzheimer's disease. There's also no evidence that I know of that the risk of getting Alzheimer's disease is any different in people with MS, and the biology, maybe most importantly, of those two conditions is different. There were a few pharmacological trials that looked promising when trying out Alzheimer's medications in addressing cognitive challenge in MS, but the largest trials have been unsuccessful. Again, that might also emphasize that the biology of the two conditions is not the same. Now, turning back to the measuring point, of course we can ask about cognitive issues, and there is a systematic way of doing that with this so-called MSNQ. It's a questionnaire, a screening questionnaire, that has a self-administered version and an informant version. This questionnaire contains 15 questions regarding recent cognitive challenges. Now, the problem with that questionnaire is that it is very good to get an idea about the subjective state of cognition, but it is also correlated with depression. So if a deficit is noted or a complaint in this type of assessment, it could also reflect depressed mood. So what we need in order to actually assess cognitive performance is some form of neuropsychological testing. So just to reiterate, although the cognitive complaints, especially if others notice these as well, are certainly to be taken seriously, a more formal testing of cognition would be absolutely desirable. This could not just verify or falsify the complaint, but also provide a measurable baseline against which to compare progression at follow-up visits, for example. And to address questions like, does cognition change or stay the same over time? And perhaps could there be reasons to change treatment or to look further into any rehabilitation? So neuropsychological testing then means the objective assessment of cognitive functions with standardized and normed test instruments. We divide here between full examination, so full neuropsychological examination and screening. Now, both contain neuropsychological tests that are, as I said, standardized. That means they are applied in the same way. If the tester is trained properly, they should be doing their exam the same way. And they are normed, so we know how people without MS would perform if they have the same age and education and gender. So full neuropsych exam is rather intense, has to be led by a clinical neuropsychologist, and it is usually guided by a specific question, like can I drive a car safely, can I live at home by myself, etc. It takes several hours, sometimes several sessions, and it's not as widely available. However, it does give the best kind of detailed breakdown on cognitive status at a given point, and can give more guided recommendations for what to do. Now, in order to overcome the barriers to availability of such exams, there have been several attempts to design screening batteries. So the MACFIMS battery, for example, is a set of 7 tests. It still does take about 90 minutes and looks into things like processing speed, learning and memory, executive functions, visual spatial processing, and verbal fluency. There's a shorter version, also widely used, the BRBN. It's repeatable, so that's good for follow-ups. It looks at processing speed, working memory, learning and memory, so long-term learning and memory, and verbal fluency. And the latest sort of iteration to make this even more practical is the BICAMS, the Brief International Cognitive Assessment for MS. That's an international initiative to recommend and support cognitive assessment that is actually practical and doable and universally available. So that said, it still contains 3 tests that do need to be ordered from the test publishers, but they're relatively easy to learn and learn to administer. They take about 15 minutes time, and it's highly recommended to do at least something like this in order to have some sort of objective measure of cognition. All that's required is a paper, pen, and a stopwatch, and some training initially for the examiner to get familiar with administering and with scoring the outcomes of these. So this does not replace any in-depth neuropsych exam, but it's meant simply as a feasible way to measure cognition, and on an individual basis then perhaps to give clues as to what who might want to get more extensive testing. And the next couple of slides give you and maybe practitioners an idea of what this actually looks like in the test session. So in the symbol digit modalities test, this is a fake example. It's not the real test. What is done is that a series of symbols is shown that go together with digits. So each symbol has a digit associated with it. And the participant would then receive a whole sheet of paper with these empty boxes underneath the symbols. And the task is to name as quickly as possible the digit that belongs to each symbol, one after the other. Okay, so this would be the start of a response. So for the first empty box, it would be a number 7. So this is the key here. So you'd have to say 7 and then 8, 3, 9, and so on. And the outcome for this test would simply be the number of correct responses in 90 seconds. So it's really easy to do. And it's been shown over and over that this test is the single most sensitive test to cognitive changes in MS. So if there's only 5 minutes time for testing, this is what I would recommend. Now the California Verbal Learning Test, again, this is not the real test, but a fake example, presents 15 words. So I would be reading out those words out loud, and would ask after I'm done that as many of the words be repeated by the participant. So I would sit down and read apple, tiger, car, shoes, and so on until I'm done with the 16 words. And the participant would then, after I'm done, repeat as many words as they can remember in any order, and would get a point score for the correct responses. And then I would repeat the list in a different order a second time, and that goes on for 5 times. So the outcome here would be the number of correct responses across all 5 learning trials. Obviously, this takes a little bit longer time than the symbol digit test, but it's a good measure for verbal learning and memory. And the last one is the BVMT, the Brief Visual Memory Test, where this kind of a sheet of paper would be shown with 6 abstract symbols, and it's shown for 10 seconds, and the task here is to memorize as best as possible the symbols on this sheet and where they are on it. So I'll show this for 10 seconds and then take it away. And the task is for the participant to draw as many of the symbols as they remember in the exact location they were before. And the scoring essentially goes like this: 2 points for the correct symbol in the correct location, 1 point for the correct symbol that was misplaced in a different location, and no points for new symbols that weren't presented. The total outcome here is the score across 3 learning trials, so this is done 3 times, and then one gets a total score. So the exciting news is that we now have Canadian outcomes in this short battery. This came out last year out of Ottawa, and that was a study in which 50 people with MS and 57 healthy people were tested, and the rate of impairment was about 58%. So 58% in the MS group had at least one of these 3 tests in the impaired range, and the most sensitive test to pick out impairment was the symbol digit test. And with these kinds of tasks, we always wonder, do they have anything to do with real-world outcomes? And in fact, in this study, they did, and in particular, the brief visual memory test was related to employment status, such that an increase in the BVMT score was related to a higher likelihood of keeping employment. So important to note here was also that some practice effects were noted. So that means if this battery is repeated and the performance levels go up, that doesn't necessarily have to mean that performance really does improve. However, on the other hand, if impairment newly emerges in repeat testing, this is a definite warning sign. So I would recommend highly that something like this as the very sort of minimum for assessment of cognitive performance be implemented as widely as possible. And the Walker study that I just showed does present an initial 4 Canadian norms and cutoff scores. So that's very exciting. So in summary, for this first part of my presentation, I think one can say that cognitive challenges are common and are related to brain changes, although that relationship is not perfect. Processing, speed, and learning memory are most affected. MS is not dementia. And neuropsychological testing or screening is needed to know if cognition is in fact compromised and to know if it changes over time. I'd say the Baycrest is an easy to administer screening and also now has data from Canada, so it's worthwhile considering that. Now, this imperfect relationship between cognition and brain, let's look a little bit further into that. These terms, brain and cognitive reserves, are from cognitive aging research, and I like to think of these things as hardware versus software. So where the brain reserve refers to the hardware, so essentially more brain tissue can be a buffer to delay onset of noticeable cognitive problems. And the cognitive reserve would be more sort of the software. In other words, having many ways to do some cognitive task may make that task more robust to structural brain damage. So now, in MS, ongoing noticeable brain changes, for example, in form of relapses, can reduce brain reserve, but it's important to recognize that MS can be active even when someone is feeling well. So even if someone is not experiencing new or worsened symptoms, the brain may be working up or using up some of the neurological reserve and try to compensate for the lost tissue. So one important finding here is that within limits, the brain does adapt to these changes and can compensate for lost function. So we're looking at plasticity, so-called. But if there's no more reserve, this type of compensation becomes impossible. So it's very important to protect our reserves as much as possible. So how does brain function actually change under neurological challenges like in MS? So very broadly speaking, to compensate, damaged brain structures may have to communicate more to each other. So what we see then is some change in the so-called functional connectivity. So the level of or intensity of communication attempts, let's say, between damaged brain regions may change. So this is an example of a study that looked into that kind of a change. So what you see here is a study on functional connectivity in people with MS, and the red blobs here, as you can easily see, hopefully here, are again in the thalamus, but this time they don't mean tissue loss, but the level of joint activation with other brain regions. So in the face of damage or structural damage to that region, its communication with other brain regions might be upregulated. So that is, this region now has to work harder together with the rest of the brain in order to compensate. So this is just one of many such findings, and we're just at the beginning of figuring out whether and when such changes in communication between brain areas in MS are functional or beneficial, and when they're perhaps not beneficial. Just very simply put, I think one can say that the brain has to work harder in order to compensate for structural changes, and that might be a main contributor also to cognitive fatigue. So this slide here is a recent schematic for the potential relationships between functional connectivity, structural brain tissue damage, and cognitive decline. So what the authors proposed here is that over time, so that's here, there might be a slow degradation in how efficient the brain networks are. So the brain regions communicating with each other, that's the green line here. And that might go hand in hand with the sort of ongoing structural changes or structural damage, that's the red line, and also with the concurrent cognitive dysfunction. So with a hypothetical steeper drop-off, when plasticity can no longer compensate for the lost reserves, so this is sort of this shaded line here. Now the goal then could be to make the red line shallower, so to slow down the structural damage and the tissue loss, and to keep the network, so the green line, as efficient as possible, as long as possible. So returning to these reserves, we do know a whole lot about their roles in cognitive aging, but how do these actually play a role in MS? This is a rather active area at the moment, and there's now more and more evidence of an influence of reserves on MS cognition as well as MS symptoms. Now, James Samowski does a lot of work in this area and recently proposed this model of influence of cognitive reserves on current status or cognitive status in MS, where he proposes that the level of lifetime engagement in so-called enriched activities would lead to better cognitive outcomes. So enrichment here refers to really a lot of different things. So that can be educational attainment, professional training, but also lifetime leisure activities, so reading books for fun, hobbies, social activities, and so on. And he also suggested that these factors may be particularly important when MS burden gets higher. So essentially, cognitive reserves like these may act like a buffer against steeper decline of cognitive functions presently. So one important thing here to distinguish is perhaps the so-called passive reserves and active reserves. So what this means is that it seems relevant how much reserves have been built up prior to MS. So a combination of educational levels, professional training, lifetime engagement in these types of enriched activities, and these would be so-called passive reserves. Now, active reserves are intellectually stimulating activities that someone is currently engaged in. So in other words, the part of the reserve that one may be able to train or to engage in currently. So I wanted to mention that here, even though it's not on the slides. There's one interesting study in this area. It's a large-scale study over 6 years that was published in 2013 by Carolyn Schwartz that looked at the role of such passive and active reserves. So again, passive reserves is sort of what we bring to the table, and active reserves is what we do right now. And so what they did, or what they found, was that these active reserves, so continued current engagement in hobbies, leisure activities, cultural activities, and so on, changed the disease trajectories in over 800 people with MS, where a higher active, but not so much the passive reserve, were linked to better outcomes with regard to time and mobility, fatigue, disability. And in addition, they also found that active cognitive reserve remains important even when the disease progresses. So even though the type of activities may change later on, they stay important. So in other words, cognitive reserves like this may provide a longer runway to disability and perhaps through changing brain function. So that was not investigated in Carolyn Schwartz's study, but it's likely that there's some sort of brain reorganization that goes hand in hand with training cognitive reserves. So in summary here, for my second part, brain and cognitive reserves are protective against cognitive decline. The brain is neuroplastic also in MS. It can compensate for some of the lost tissue, but that requires energy and becomes less likely when these reserves are getting smaller. So now to the last portion here, what is it that we can do? What's the evidence? So very, very simplistically, as much as we can, it's a good idea to keep the brain as healthy as possible and to keep the mind as active as possible. I'd argue there's good evidence now emerging that this also refers to body health, and I'll get some examples of that later. Now, unfortunately, pharmacological interventions for symptomatic treatment of cognitive challenges in MS have been largely disappointing with regard to specific drugs that would address cognition. Now, we do have good evidence that the disease-modifying medications in relapsing MS are also protective of cognition, but there's really mixed on all findings for progressive MS and for other drugs. Medicinal versions of amphetamines have been promising in recent trials. There's an ongoing trial on Adderall headed by Sarah Morrow in London, Ontario, and that seems promising to address processing speed changes, but we do urgently need alternatives. Now, what about cognitive rehabilitation? That is another very hot topic right now. There's been maybe about 25 cognitive rehabilitation studies now. Most of them are cautiously positive, let's say that. I just wanted to show one of these. So in the MemRehab trial, the intervention here was a cognitive rehabilitation strategy, the so-called story memory technique. They had people read out loud stories in which some of the words, so it's essentially trying to make people memorize words better by creating visual imagery and by putting these words into a story context. So they essentially had people read out loud stories in which some of the words they were supposed to memorize should be learned for later memory tests. And in the first half of the training sessions, they had to visually imagine these target words in their minds. And in the second half of the sessions, they had to invent a story including those words. So this type of rehab technique makes use of the fact that we humans have much better visual memory, usually, than a verbal memory, and that we can more easily retrieve information that is embedded in some sort of meaningful context, so rather than some random words from a random list. And this was a successful trial. The learning curve in the California Verbal Learning Test that I just showed did improve for the intervention group, but the intervention also made everyday memory better. That's an important point for cognitive rehabilitation. What we sometimes see that there's little transfer such that the trained function might get better, but it doesn't really translate to other things. So we want to make sure in these kinds of interventions that there is transfer. In this particular trial, that was the case. And it also lasted for 6 months after, so that was good news too. However, there was a bit of a caveat here. People who were enrolled in the trial did have to have memory deficits to begin with, but those who had memory problems and processing speed problems were less benefiting less from this intervention. There's now been a couple of newer studies exploring other kinds of rehabilitation interventions. I did state here they had more mixed findings. It's kind of hard to evaluate overall. There's been meta-analyses, Cochrane reviews that try to summarize the state of the evidence right now, and it's really, we need more research. So one set of recent studies used computerized at-home cognitive rehab interventions, and findings from these studies have been quite positive overall. On the other hand, there was a larger trial published in 2014 that was carried out on over 100 participants, and they had a strategy-based intervention and showed that that didn't actually improve objectively measured cognition, but it did reduce perceived deficit and quality of life. So the verdict is still out there. I would say we need more research to find out who benefits most from which type of cognitive rehab and how much is needed. So it's very important also to note that most of these studies have been done only with people who had relapsing remitting MS, and we urgently need more cognitive rehab studies that include other forms of MS as well. So turning to sort of at-home strategies and technique, the US-based National MS Society put a nice summary together, I think, that I wanted to share with you regarding so-called restorative and compensatory techniques. So restorative techniques can include learning and memory exercises, such as combined modes of learning. So that means you'd would be more likely to remember something if you see it, if you say it, if you hear it, if you write it, etc. So it's more likely if you have several modes of learning the same information to then later retrieve it. Repeat and verify means repeat what you hear and verify that it is correct to improve attention memory. Spaced rehearsal would be repeating and practicing information over time. So repeat and practice once, take a break, repeat and practice again, sort of later on. And building associations would be to use memory aids. So for example, to remember the name of someone you just met, associate that name with a friend or family member of that reminds you of that same name. So concretely, if you meet somebody who introduces herself as, "Hi, my name is Anna," you want to remember the name Anna, you can say, "Hi, Anna," so repeat the name, write it down, put it in your phone, or you can build associations by thinking about your grandma Anna, Anaheim. And one thing that wasn't on that strategy list that I think is probably quite successful would be visual imagery. So as I said already, humans are very good in learning visual information. If you imagine the word Anna dancing in red letters above Anna's head, it's very hard to get that image out of your mind. So it might be a good idea to use something like that. Now, compensatory techniques are intended to make up for functions that are weakened, and they can include a whole bunch of things. So consolidation and centralization here would be sort of creating a command central somewhere in your house. So the Grand Central Information Center, so to speak. So that could include a master calendar, mail, bills, phone messages, to-do lists, keys, and so on, just that they are centralized in one place rather than many places. Now, plan would refer to posting a calendar large enough to display everyone's appointments, activities, social engagements, and so on. You could record your to-do lists, for example, into your phone. You can use checklists or the alarm on your phone or timer and so on to set reminders. It's important to eliminate or remove yourself from distractions if these pose noticeable sort of challenges. So turn off the TV or music or whatever else is on. For example, when you're speaking to someone on the phone or in person, background visual and noise distractions can make learning or remembering more difficult. And if you can't eliminate the distraction, for example, you're with a lot of people, they're talking, then you could ask to move to a quieter place, perhaps. It's important to take breaks. There's no shame in taking breaks. If you are having difficulty concentrating, do that to refresh. And it's very important also to do one thing at a time. It's not always avoidable, but the switching back and forth from one topic or task to another could be particularly straining. So if at all possible, it's better to do things sequentially than trying to accomplish multiple things at the same time. So now, I wanted to mention very briefly the role of physical activity. There's now been several studies suggesting that physical activity may improve cognition as well as other symptoms in MS. We're talking about aerobic or cardio exercise in particular, and some of these have generated evidence for brain changes as well. So these are two studies. The first is a single case, and this is a small-scale study in 8 people with relapsing remitting MS, where they introduced an aerobic exercise over 12 weeks. So that was progressive treadmill walking or stationary cycling exercises. And both studies showed some improvement in learning and memory, as well as, that was in the case study, an increased volume of the hippocampus. So that's quite dramatic. The second study with the 8 people showed that in the intervention group, there was less tissue softening, which is going hand in hand with a bunch of neurodegenerative conditions, again in the hippocampus. So that's quite exciting. The hippocampus is the one area in the brain that we know can actually generate new nerve cells, and if we have a way of targeting that, perhaps it might be a way to go. Now, this is a study that I was also very excited about because it actually was targeting only progressive MS and still looked at physical activity. So in this study, they included people with only progressive MS and had 3 different aerobic exercise groups, had 8 to 10 week duration, and they measured cognition along with all sorts of other outcome measures. I'm focusing on cognition here right now. And what they had here in terms of intervention was rowing ergometer, an arm ergometer, or a bicycle ergometer as well. And they found memory improvement in a verbal learning test. So this is wordless learning. It was in Germany, so this is a different test, not the California verbal learning test, but it functions very similarly. So what you see here is improvement in all 3 intervention groups compared to control, both in the immediate learning as well as in delayed recall. So this is memorizing the words after some times, after 30 minutes. So that's quite exciting. And so in summary, I think what for my what to do portion of this, I think there's good evidence to suggest that mental activity is and stays important also later on. And this does not just refer to specialized cognitive rehab, but really also leisure activities. So continued engagement in social interactions, in things that are enjoyable and ideally mentally stimulating. Using specific strategies perhaps to help focus and remember things, such as creating your information central and enriching your learning by building associations or using multiple modes, using reminders and so on, are likely to work, not in everybody and not every strategy, and I'm not trying to suggest that everybody use everything here, but it's really a matter of trying to find what works. And I think we have got some good evidence now to suggest that cardio exercise, so things that make you sweat, are probably a good idea to try or to continue doing. Now, in the very end, I wanted to share with you a policy guideline document on brain health in MS. I'm not associated with this document, but it summarizes also some of the points I raised here today. It also addresses other treatment and lifestyle recommendations that I had no time and no expertise to go through here in detail as well. So, for example, nutritional guidelines or guidelines regarding the use or non-use of alcohol, nicotine, those kinds of things. So lifestyle factors that would essentially help keep brain health high as long as possible in order to delay or slow potential for cognitive decline. And with that, I am at the end of my presentation. I'm a little bit early here, so what I wanted to take some time to do is perhaps answer some of the questions that I was given beforehand. Jillian, maybe you can let me know how this works best.
You know what, I think, why don't we jump into some of the questions that people have right now?
Sure, yeah.
And then if there's time at the end, we'll go back into that, because I want to make sure that those that are in attendance have their questions answered first.
Of course, yeah.
And there's no way of me knowing either one. So what I'm going to do before we go into that, I would like to just remind people, if this is their first time joining us, the process to which, or the options in how one can ask a question. So there's two ways. You can type your question into the chat pod, which I see some people have already started to do, which is great. And then just a quick reminder about that only Dr. Fujiwara and myself and our colleague from the MS Society, Katie Lacey, can actually see the question that you've posted. So your fellow participants that are joining you today all across the country will not be able to see your question. And so just in case you want to make sure that it's anonymous or that you keep your privacy, no worries about that. The other option is that you can ask over the phone by pressing *7, and then you can just ask by talking to our presenter directly. I would ask that only those who are interested in asking a question over the phone to unmute their line. The rest, if you can just hold tight in the way sort of status quo. And the other thing to note is that we will be posting some poll questions, and I'll put the first one up now. And so we're going to be posting about 5 questions throughout the next half hour. So I encourage you to all answer those before you leave the session. And your answers are anonymous, but it helps the MS Society of Canada tailor future webinars and make sure that that they're meeting the needs that you have from this one. So there have already been some questions posed, so I'm going to jump right into those. So the first question is, please comment on the use of modafinil, I hope I'm pronouncing that right, to enhance cognitive functioning in MS and whether there has been any research in this regard.
From what I remember, I don't think it works. There's been at least one trial. Let me just check real quickly. That was only partly successful. And no, I would not say it's a a recommendation.
Okay, thank you.
Yeah.
Person asks, my MS neurologist told me that neuropsych testing was not necessary because there is no way to help if there are cognitive changes, which I have: memory, processing speed, executive function, reading, etc. Can you?
Yeah, as I said in my presentation, I think it is actually better to get proper assessment, even if it's just to get verification, first of all, because we do see changes, cognitive changes, that are not due to actual cognitive decline, but due to mood changes, etc. So first of all that, and on the other hand, there are cognitive rehab, for example, strategies that even if the evidence is not clear-cut at this point across the board, there are ways to address these challenges. So I would beg to disagree with that opinion, and would definitely recommend to have some sort of screening at least done.
Thank you. And we certainly encourage knowledge exchange in this format, and I do want to provide people with any comments that others have left. We do have one individual, going back to that comment about modafinil, that it actually worked very well for one of our participants. Quite extraordinary, she says, but that she can't take it due to the adverse effects. So I don't know if you want to comment further on that.
Yeah, I'm not a medical doctor, so I can't really say anything definitively about a single case, but I just know sort of from the research that it was only partly successful in the trial. So if that works for an individual person, this is great, but yeah, from sort of a recommendation view, I would not be able to comment.
Fair enough. Okay, thank you. Okay, so we're going to move on. So this person is specifically asking about amphetamines, example, e.g. Adderall, to help with cognitive functioning. What is suggested if a person with MS has anxiety and/or panic attacks?
Yeah, that's a big problem. Actually, I'm sort of peripherally involved in the Adderall trial, and we have quite strict exclusion criteria because of that. So it would be a problem, of course. We don't want to be inducing any other additional symptoms with giving such medication. So as I said, it's just an investigational stage right now. So we'll have to see what the final outcomes are of that trial in order to make any sort of more definitive recommendation in that regard. But definitely that is a concern.
Thank you. And okay, moving forward again, there's lots of great questions coming in, so I'll do my best to get to them all. Is there a comparison between the MMSE or MoCA with BiCam? And perhaps maybe for those who don't know, you can speak to what those things mean again in terms of acronyms.
Right. So the MMSE and the MoCA are screening batteries that were not designed with MS in mind. So these are screening tools that were meant to pick out dementia. So the MMSE has been around for decades. And yes, if there is an impaired score in the MMSE, that is usually a warning sign, but it is not sensitive to pick out very mild impairments or very sort of minor issues. So generally, I would not recommend relying on the MMSE in order to stage or detect cognitive changes that are more subtle often in MS. So the MoCA is a bit better that way, and it has been used at least in 2 or so studies. But the direct comparison I'm not aware of right off the top of my head between the BiCams and these two. Now the BiCams has been designed over many years to really be sensitive to the most sort of the smallest denominator, basically, the tests that are most sensitive to what we generally think is affected most in MS and not in dementia. So I would recommend that over the MoCA and MMSE for sure.
Thank you. Okay, so this individual asks, do you know of the study of Lycera stopping new brain synapses from growing? And also, can I ask my neurologist how much my brain has atrophied based on my MRIs?
Okay, so I did not understand the substance.
Is it Lycera or
Lyrica. Okay.
Lyrica. Excuse me. I'm sorry.
Yeah, no, I don't know. I'm not aware of that study in particular. So what did Lyrica do?
If they stop new brain synapses from growing, this is her question.
Oh, I would have thought the other way around, but no, I would have to know about the study in order to make any call on that one. Okay. In general, as I said, the depression. So this is addressing depression, perhaps. So depression does influence cognition, and it is important to address mood changes in addition. So how on an individual level, that's really not my call to make. That would be, the practitioner. But yeah, so cognitive changes can be masked sort of by depression. And we will hear, I think, in the next webinar from Dr. Feinstein just about mood and cognition. So that would be better expert to ask, I think, with regard to that question. Now, the second question was how much brain change was observed or was present in an MRI, or? Yeah,
can she ask her neurologist about how much or if her brain has atrophied from the
okay, okay. Yeah, okay. So, I mean, as I said, the example in my slides was kind of extreme, so that would be sort of visible to the eye. But generally speaking, there's not a standard for assessing atrophy, sort of a whole brain, unless there's a radiologist who would note that as a finding, clinical finding in the follow-up MR. But of course, by all means, ask if you want to have a clinical opinion on that question. Definitely, the neurologist should be able to at least address it.
Thank you.
Mm-hmm.
Okay, so we're going to keep going because there's lots of questions coming
Okay,
in.
good.
Are neuropsych testing and BICAMs impacted by one's educational background? And he gives examples such as a PhD being tested versus a high school graduate.
Yeah, they are in general. Of course, they are, and that's always a problem, or always not a problem, but it's always very, very strong, these influences of education as to what we should be seeing. And that's why we do need neuropsych testing, because we have norms that correct for these things, right? So we would not necessarily know from one test score if it is an impaired test score or not, if we don't have references to compare that score to people without MS or without any kind of neurological condition who have the same education, the same gender, the same age level in order to make a call on that.
Okay.
Mm-hmm.
And do all neurologists test for this, or is it only specifically those associated with MS clinics?
They should. No, they don't. But I think there's good points here, or really concerted effort to make this as practicable as possible. So I think it is a good idea to have this more widely implemented and not just in specialized settings. If at all possible, I would definitely recommend this.
Thank you. Okay, so more questions. Everybody's great. This is wonderful. Are you hanging in there? You are?
I am, yeah.
Okay, perfect. Okay, so are the activities that you suggested for memory any different than for people without MS? So some of the strategies that you talked about already, are they specific to those with MS, or are they work for the general population as well?
So the to-do at-home strategies or the cognitive rehab strategies?
He just asked the activities you suggest for memory.
Okay, yeah. No, these are broad, and they don't really are restricted. They're not really restricted to people with MS specifically. They are just sort of selected as strategies that are known to or have been known to help with the symptom. So the symptoms of, say, processing speed problems or memory problems are also not that specific completely, entirely only to MS. So we do see things like that in other, in cognitive aging even. So does that answer the question perhaps, or I'm not sure?
Well, we'll let the gentleman who asked if
yeah. Okay. So no, I mean, they've not been designed specifically and just for MS, but to address a symptom that is common in MS. Let's say that.
Okay, and he's saying yes, that answers your question. His question.
Okay.
Okay. So we're just going to keep going here.
Mm-hmm.
So are there any tips for helping convince long-term disability providers that cognitive issues have happened and do have an impact on one's having the ability to continue to work?
Well, I mean, I think first and foremost would be the assessment portion. So has assessment taken place or not? And so with neuropsych testing, has it happened or has it not happened? And if it has happened, there's some objective grounds on which something like this could be recommended. So if it's more of a subjective feeling or an impression or a clinical judgment, that's generally speaking harder to convince anybody of, as opposed to actual evidence. So again, that goes back to the measurement question. So I would turn that question around perhaps, or back.
And I'm gonna back that up with some further questions that a couple of people have asked in keeping with this theme, and that is, how often do you recommend the neuropsych testings be done, and at what point do you start them?
As early as possible, and at least once a year, I would say, so that we have, or that there is some sort of continuity that goes along with care. Ideally, I would say this would be integrated into the clinical day-to-day. So yeah, that would be my short answer.
Okay, thank you. Okay, so we're going to change gears here a little bit. This is particularly interesting in light of the revelation this afternoon or this morning from the Government of Canada. How does the use of cannabis affect the cognition reserve?
So that research is quite new, and I know, again, Dr. Feinstein does a lot of that research himself, so he might be able to also answer better to this next time. But anyways, very briefly, or generally speaking, there is no good evidence to suggest that one way or the other, first of all, especially not with regard to reserves. So with regard to cognition, it is a dosage question, I think. But yeah, I don't want to say anything wrong here right now, also in terms of policy. But yeah. So we do see differences or influences, especially with acute sort of medication, but it depends on the dosage, of course.
Okay, thank you. Yes, that's a tough one to navigate through right now. Okay, we'll keep going. So this person is asking about the aerobic studies with improvements in ability and lower tissue degeneration. He says, you say it's possible to improve, but is there anything that can be done to regenerate damaged cellular structures once the damage has occurred?
Yeah, this was actually regarding the hippocampus, and so if there's a volumetric change in visible on an MR, that does imply some growth. So what happens with the aerobic exercises is that the oxygen, or basically there's a production in so-called growth factors, and that will influence generation of new nerve cells. There's only one area in the brain that can do that, and that is the hippocampus. So that is partly why this is such an exciting finding. So if we can indeed target that process and stimulate new growth, perhaps in that area, that'd be very exciting. Now, we definitely need more evidence and more studies in order to say anything more definitive here, but that would be exciting.
Definitely. Okay, and so going back, I know I'm jumping a bit here, but people are coming and commenting further about the conversations having to do with neuropsych testing, and I think it's important that we touch on this just because it seems to be an area that there's a lot of interest in right now among our participants. So with respect to when you said that neuropsych testing should be repeated each year, how long is the process? Is it a day, or is it an hour or two? And is it expensive?
Yeah, so it depends on what you want, you see. So if you want the full neuropsych examination, that is probably not very easy to do and not very widely available. And I'm not sure, it depends on the insurance providers and the sort of diagnostic mandate, or who refers who, as to whether that's covered or not. So that would be more extensive, obviously. What I was advocating for is sort of the minimal standard would be to include neuropsych screening, which takes 15 minutes if you use the Baycrest, for example, And that should be certainly possible, even in the normal sort of care setting, I would think.
Okay. And are there one or two screening assessments that you would commonly do that would pick up the need for further assessments? And this person is asking about, for instance, the SDMT or the BVMTR, or are there other assessments that are commonly used?
Yeah, so what I listed here right now were sort of consensus-type batteries that have been designed at several stages in history. So the MACFIMS, for example, is a 90-minute screening that does include more tests. So there are others that are harder, perhaps, to implement in practice. But the three tests, especially the symbol-digit test, are quite sensitive to pick out even, mild issues early on. So that would be sort of my go-to.
Okay.
If I had 5 minutes time for testing, yes, so that would be the one test I would use.
And just going back to answer the question of the individual had about how long it would take and so on. So we've just had a bit of feedback from participants. So we have one person from Ontario who said that when she had it done, it was done through an MS clinic. It was a half day of testing, and they did not pay for it. There was another clinic based out of Alberta who said at their clinic there was a 9-month wait list for a neuropsych, and it can range from a half a day to 2 days. So it seems to vary quite a bit depending on what province you're in.
And also what the goal is, you see. So if there's a very specific question, such as can I drive a car or can I live independently, these questions require quite a bit of work, also through the charts and the sort of medical records, in addition to just cognitive status assessment. So that's a bit of a different goal here than a full neuropsych examination would have.
Right. Right. So and Ontario, again, another gentleman has mentioned his neurotesting was 1 full day and was covered by the MS clinic in Ontario. So it really does seem to vary, absolutely, in terms of also what the objective is of the testing as well.
Absolutely, and also the availability of the actual clinical neuropsychologists that are more frequently to be found in Ontario than elsewhere, for example. So if there is a long wait time, that might just be because there are not as many professionals who are licensed to do this in all places in Canada.
Thank you for that. So I'm going to talk a little bit about cognitive fatigue, because there's been a few mentions here. So I'm going to refer to a particular case that one individual shared with us. She says, I have RRMS diagnosed 2 years ago, lots of cognitive issues since before diagnosis. I have tried a number of these strategies, but I find the cognitive fatigue sets me back and takes a few days to recover. How do I figure out the balance between doing these strategies and gently pushing limits versus overdoing it?
Yeah, that's a very individual choice and decision everybody has to make in order to figure out where the limit is. So none of these things, and that's also part of why I try to emphasize the leisure activities. Right, so leisure activities sort of by definition means do things that are fun and not those that are stressing you out. So the stress or added stress by trying to implement strategies that don't work for you is not helpful and definitely would not be beneficial for improving anything. So I think the joy or the fun in whatever type of cognitively stimulating activities should not be underestimated here. Yeah, so then specific strategies back or forth, that's not the final word.
Fair enough. Okay, thank you for that.
Okay,
so we're going to last 10 minutes or so we still have questions coming in, and thank you all for participating to continue to answer these poll questions as we go through. the next 10 minutes or so. So another question has to do with lesions versus inflammation. So can you speak about cognitive issues with MS between lesions versus inflammation? Inflammation wanes, and I'm aware they go together in MS, but sometimes inflammation can be far more prevalent, and it self-improves over time in a patient, with diet and exercise, etc.
Well, I mean, the strongest relationships are not actually between these things and cognition, but between gray matter changes and cognition. So that, I mean, if you see the direct sort of relationships, the gray matter loss is probably the most important with regard to cognition, right? So, in other words, if you look at a nerve cell, it has a nerve cell body. That's where the computation takes place. That's what the gray matter is. The white matter is sort of the connections between them. If that breaks down, yes, we have some slowdown of processing speed, those kinds of things, but the relationships are usually weaker there. So I know it doesn't directly answer the question, but
no, I think you're getting lots of questions thrown at you, so I think you're doing a great job. So
okay.
So, and then we're going to again move to some of the other, variables that people can try. So this person asked, are there things like sleep hygiene or pain management that should be considered?
With regard to cognition specifically, I wouldn't be able to comment on that. I mean, more sleep or better sleep hygiene is probably, generally speaking, beneficial for cognition, not just in MS. I mean, in general, if we are considering these, reserve capacities of some kind, anything that benefits brain health would play perhaps even more of a role in MS than it does in everybody in cognitive aging in general. So then those things obviously also would play a role in MS as well. But specifically, I can't say.
Okay, fair enough. And this person is specifically asking about whether acupuncture has been shown to help with cognition and fatigue. Can you comment on that? Do you know anything?
Not in trials or not in sort of, scientific evidence. So that's, I know for sure. If it helps in an individual case, that's great. And I don't doubt that it does in some cases, but not in terms of studies.
Fair enough. And this person mentioned, she says she's curious. She was an avid reader of difficult books. One of her most frustrating issues is the inability to follow plot. Reading is very fatiguing now. Would that be a consequence of a lesion in a certain location or brain fatigue in general, or is that too hard to say?
It's hard to say on an individual basis for sure. It could be any one of these. I doubt that it is a specific lesion that would cause that kind of difficulty, and it's more probably sort of a systemic general sort of effect. So I don't know, does that answer the question, or?
I'll let her be the judge. We'll see if she says anything. Yes, yeah. She says.
Yeah.
Okay. And this actually, and maybe, Dr. Fujiwara, I'll give you a bit of a break, and this maybe goes out to everyone who's still on the call with us. And this person is asking about, if someone does have neuropsych testing, is there a way to prevent the release of results to employers or insurers? And I don't know if others have had experience with this or not, or if this is an issue to even be concerned about. But this person was requesting this information. So perhaps people can share.
This is Katie at the MS Society in Edmonton. Just off of the top of my head, I can see why there might be concern about the results going to an insurance provider, because sometimes when one applies for insurance, they give the provider consent to contact their doctor, contact specialists to verify that the information that one's provided is accurate. so perhaps if one has undergone a neuropsych test and has consented that the insurance company can look at their records, yeah, that could be worrisome. As far as the employer, though, having access to that information, I wouldn't think so. I would think that
authorize it.
Yeah. Yeah, Esther's agreeing with me that one would have to authorize the employer to have access to that information.
And then, yes, and there's another individual who's mentioned in the chat pod that for her, she had to authorize it.
Mm-hmm.
So that's good information there. And then also another person has shared, just as a comment, that there's an ongoing study in Ontario on exercise and aerobic activity and cognition. Results are not out yet, but personally his memory results in the pre and post testing did improve a fair bit. So
that's great.
That's wonderful. So thanks for sharing that as well. And then there was another comment to the person that was having problems following plot lines and finding that reading was quite fatiguing, that another participant mentioned that their sort of strategy for that was to consider audiobooks, that they found them to be hugely helpful.
Yeah, that's wonderful. Yes, good idea.
So, and I know just as a personal, that my local library, I live in a very small town in eastern Ontario, and even our library has a ton of audiobooks. So if a little town in Ontario can, I'm sure that there's others, libraries that have them as well.
Great.
So that's wonderful. Sorry, I'm just reading here. So another person has mentioned about the neuropsych testing and releasing it to insurers and so on. This gentleman shares, my neuropsych testing did show a significant impact, so we did share it with the insurer. It seemed to have an impact on their decision making since the neuropsych testing was so significant. So food for thought there. Yeah, so lots of good information here. Okay, so I'm just going to look here. I know we have a very short period of time. Another person has mentioned about podcasts. They're great because they're generally shorter, so these are great information about just different strategies to combat some of that fatigue. And actually this is a bit of a different sort of take or a question, Dr. Fujiwara, so maybe we'll tackle this one in the last few minutes here. What is your recommendation on how this information could best be utilized for residents with MS in a long-term care home facility? That's something that we haven't touched on quite yet, so maybe we'll talk about that for a little bit.
That is true. So lots of the evidence does come from relapse-remitting MS and not progressive and not sort of later stages. So I think the sort of the broader strategies could still apply in that kind of setting, but yeah, in terms of creative ideas on how to convey this information, is that the question, or?
Yeah, just and how this information could be best utilized for residents that live in a long-term care home that do have MS. Yeah, as I said, perhaps the sort of closest angle on this with regard to what I looked at here is the leisure activities and the sort of social engagement, even in that kind of a setting, that does seem to play a role and does seem to buffer against further decline later on, no matter what disease stage, or what sort of the current status is. I think that Caroline Schwartz study was a very sort of hopeful study in that regard. I think that could definitely be emphasized more, so that we're not looking at, brain jogging or brain training in that sense, but keeping the reserves that are still there, while still doing intellectually stimulating or enjoyable things. That's great. So I think we're at that point. It says 4:29 on my clock, so I think we have to call it a day here and probably let Dr. Fujiwara have a breath.
Thank you.
It's been a lot of great questions and comments and involvement, and this is just fabulous. But I am aware of time, and I don't want to take anybody longer than what we already planned for. So just a big thank you, sincerely, to everyone for their participation this afternoon. It makes such a wonderful event when we have this this type of interaction. And of course, this couldn't occur, of course, without the MS Society of Canada and Dr. Esther Fujiwara. Thank you so much for your participation in today's event. I mean, there's a lot of work that goes on behind the scenes long before we ever get to today. To make this all happen, so thank you both. I just want to send out sort of 3 little reminders before you all head out the door, virtually speaking, of course. One, that is a recording of this webinar will be available on the MS Society of Canada website within a week or so, and so you can check it out there. Today's event is the 4th of an 8-part learning series, so we'll keep you posted on future events, and one was already mentioned. Next month it's looking at mood in MS with Dr. Andrew Feinstein, so check that out on the MS website as well. It also will be on Brain Exchange, I should mention. And that very shortly you'll receive an email requesting your participation in a survey from MS Canada. So that's going to be sent directly into your inboxes, and so you can check that out as well, and we invite you to take part in that. It does not take very long at all. So at this point, just would like to invite Katie Lacey of the MS Society of Canada to say any final words.
I would just reiterate your thanks to everyone who participated. Hopefully you found it to be worthwhile. I know that I certainly did. And yes, again, the webinar will be posted in about a week's time, and then you can share it with others or listen to it yourself again.
Wonderful. And I'm going to post, someone was just asking just where they can find that information. So it's just in the about pre and post or previous and future events. So I'm just going to post that again just for people to check out. And then you can also access the slides on Brain Exchange as well, a copy of today's slides, and they're also in the chat pod, that link as well. So that was a lot of information, everyone, but thank you so much for sticking with us. It was great. And until next month, when we do this all again, and Dr. Fujiwara and Katie, thank you so much for your time as well.
You're very welcome.
All right. Have a good afternoon and evening and wherever you are across this country. And take care, everyone. Have a good day. Bye-bye.